So welcome families, professionals, and researchers to our first annual SETBP1 Virtual Family Conference. Yay! I still can't believe Simon's VIP Connect has provided us this unique opportunity to connect, to ask questions to knowledgeable experts in the field of neurodevelopmental disorders, and to learn more about SETBP1 disorder, which impacts all of our lives in a substantial way. Thank you, Dr. Wendy Chung and Simon's VIP, for acknowledging the challenges our community faces. Sorry, Wendy, if you were speaking up. and adding our gene to your list of genes you research and focus on. And also thank you, Dr. Wendy Chung, for collecting, organizing, and taking the time to present your findings to our community today. And thanks, Lindsay Kartner and Caitlin Singer, for all your help and for taking care of the communications and logistics for this conference. And thank you, Dr. Siddharth Srivastava, hope I said that last part right, aka Dr. Sid, for being the specialist to step forward and to commit to researching our disorder in detail and to have the desire to become the expert for SETBP1 disorder. And we appreciate you taking the time to share with us your presentation today on developmental medicine that we'll get to hear. And lastly, thank you to all the families that are on the call with us today. So I mentioned earlier that I'm the president for SETBP1 Society, which is our nonprofit dedicated to SETBP1 disorder. Our mission is to provide support to individuals with SETBP1 disorder and their families, to promote discussion and fund research, and to bring awareness and education to the public. We believe our organization will bring targeted treatments to individuals impacted by SETBP1 disorder by focusing on our mission. As an organization, our idea of targeted treatments include proven or customized teaching methods, programs, and/or therapies that help our children learn more effectively, medications that are crafted for individuals with SETBP1 disorder, and one day a treatment that permanently removes the barriers that SETBP1 disorder creates for our children. So we wanted to share some highlights from 2017. We supported a growing community on Facebook, which started out with 3 at the beginning of the year and grew to 23. And thanks to Jean-Francois and his family for getting that started originally. We formed our nonprofit, including our board and medical and scientific advisory board, and we raised over $12,000 to put towards research for SETBP1 disorder. We helped move research forward by connecting with over 50 researchers and biotech companies all over the world, and aided in the initiation and expansion of our community involvement with Simon's VIP. And although I don't see that we highlighted it here, we have 2 doctors specializing in SETBP1 disorder. So in addition to Dr. Sid at Boston Children's, we also have Dr. Breguet van Bon at Radboud Medical Center in the Netherlands. So for 2018, our focus will be to fund our first research projects. The projects will be, number 1, to create a biological model of SETBP1 disorder to help us understand the affected neural pathways and the molecular and cellular impact of SETBP1 disorder. Now, this biological model could be a mouse model, or it could be a human iPSC model. iPSC stands for Induced Pluripotent Stem Cells, and iPSCs are derived from skin or blood cells that can become practically any type of human cell. And they can serve as an important tool for modeling and investigating human diseases, as well as for screening drugs. So similar to how an animal model would help us. The second project is to develop a diagnostic journey of SETBP1 disorder guide. And that'll help us to further understand the direct impact of SETBP1 disorder on the families and the individuals themselves. And then how will we fund these projects? So we aim to fund them through funds we've raised in 2017 and through our upcoming Rare Carousel of Possible Dreams fundraiser. And our goal is for this new fundraiser that we're launching will be $25,000. And the combination of those funds will go towards these 2 research projects. So 2018 is the year for hope. Be the hope, be the change. And I'm more than happy to talk more about our plans or about SETBP1 Society in general. So if you have questions after the presentations wrap up, we can talk about it more. So thank you.
Merci, Eric.
Okay, so we'll go ahead and transition here. Lindsay, if you can control the slides, just go to the next slide. Yep. So for the agenda today, in terms of what we're doing, this is Wendy Chung. I'm going to be talking about the data that some of you have contributed to the Simon's VIP study, and I'll go through also some questions that we got ahead of time from the group. So thank you for sending those. And then we'll save a little bit of time for the group to respond if there are questions as I'm going through. If you don't mind, either you can, again, as Lindsay said, chat and send your questions to her in writing as we're going through if you don't want to forget them. But we're going to hold the questions for that question and answer period at the end of that, if that's okay. After that, Dr. Sid is going to go through some, what I hope are going to be very practical tips and some questions you may have had about medications for your children and some ways in which those can be effective. And again, at the end of that, we'll save some time for questions. This also, as Lindsay was saying, is going to be recorded. So the reason we're doing that is that if any families happen to be diagnosed later, we want to make sure this information is immediately accessible to them, as well as if any of your providers, any of your doctors or therapists or anyone else might want to hear about this in the future, they can be able to go on and get this at any time in the future. However, this recording part that we're talking about, as Lindsay said, we did not record the part at the beginning where we individually identified who you were, because we're trying to keep all this information not labeling you, so this information is private. And so we're going to actually stop recording at about 4 o'clock when we finish this, but we're going to leave the line open for the families only, so that if you all want to talk about anything either that you heard today or just in general, be able to talk about your kids or challenges you've had. That way you can talk about it, and you can talk about it very freely. That's not going to be recorded, and we're not going to be on the line listening. So if you want to, be able to say anything very private, you can certainly do that. We will end that open line on the call, though, at 5 o'clock. So if you still have things you want to talk about afterwards, take them to email or wherever you guys are talking, but we will close the line at 5 o'clock. Okay, next slide. So the Simon's VIP program, we actually started several years ago to think about different genetic communities where these genes were related to, in some cases, autism, but more broadly, neurodevelopmental disorders. And so we had invited individuals to be able to work with us to understand these conditions better, to be able to serve as a resource where we could learn from each other, as well as to be able to make it easier for researchers to work on these conditions, because many researchers might be brilliant, they might have great ideas, but they might not have direct connections to the family. So we wanted to make this easier for them. This is obviously completely voluntary, but for the individuals I'm going to talk about 5 individuals that have participated from the community today. And again, none of the information is identifying any one person within this. I will say that it's limited. What I'm going to be able to tell you about today is limited because it's only 5 individuals, and I don't know that this is representative of the full spectrum of what we see with SETBP1, and you're also going to see that it's somewhat limited in the age distribution that we're seeing. So individuals, exactly what this is going to evolve into and what the challenges may be for young adults or even older adults, I really don't have that much information so far, but I hope over time, more people would be diagnosed and we'll be able to answer those questions. Next slide. So just a very, very brief primer in terms of the genetics for everyone, at least on the group that I'm talking about today, and it's generally true for the other individuals, at least that I personally know of with SETBP1. These are things that are encoded within the genes that tend to be, as I'll talk about in a second, new genetic things that were not inherited from either one of the parents. So this is something that we call a spontaneous or a de novo mutation. This condition, as I'll show you in a second, can actually result from either a region of the chromosome that contains the gene for SETBP1 that's been deleted, or it can come because there is one usually single letter alphabet change or a very small number of alphabet changes within the SETBP1 gene. Next slide. When we see these, as I said, most of these are actually new genetic changes in the child. So I'm trying to show that in the bottom left with the boy that has sort of the bright rays around him. We can see this in boys or girls. It just so happens in the series I'm going to tell you about today, it happens to be boys, but there's no reason there should be girls should be protected from this. We can see it in either sex or either gender. Next slide. Because these are new or de novo genetic changes, for anyone who might be thinking about having other children, any parents of a child with a SETBP1 change, there's a very, very low risk, but it's not zero, that it would happen again. So what I mean by that is the genetic change itself could theoretically occur in the egg or the sperm and could be present in additional egg or sperm for those parents. It doesn't happen very often, but that could be the case. So generally we say there's about a 1% chance that it could happen again for a future pregnancy for those parents. For the siblings of a child with SETBP1 or more distant relatives, cousins, nieces, nephews, things like that, they really don't have any risk. So we're not, excuse me, we're not really worried about those other relatives. In theory, if an individual with SETBP1 were to have children of their own, then there would be a 50-50 risk for that person to pass it on. So that may or may not be an issue for certain individuals, but theoretically that is, that's what would happen in terms of them having children in the future. Next slide. So as we're going through this, one of the things I wanted to try and clear up in terms of what could be a confusing point is that there is one gene, SETBP1, but it's associated really with two different conditions. And although there are some similarities between the two conditions, there are some important differences. So there's a condition that was actually described a while ago called Gideon Syndrome, and I want to be clear that is not what I'm talking about today. That condition is again due to changes in SETBP1, which I'll show you in a second, but it's due to that gene being overactive or being in overdrive, and we call those gain of function mutations. Now, for everyone, I hope on the line today, we're actually talking about the SETBP1 condition, which is in some ways just the opposite, in the sense that the SETBP1 gene, at least one of the two copies of SETBP1 is not working correctly and is actually in many cases not working at all, or is what we call a loss of function. So if you want to think about it, if normally people have 100% of SETBP1, Gideon syndrome would be having something like 150% or 200%. It would be an overdrive. And for your kiddos, they would actually have more like 50% or less in terms of that. And that can either be due to, as I said, deletions of the whole region on the chromosome around SETBP1, or maybe due to specific changes within just the one SETBP1 gene. So for individuals that have deletions of SETBP1, the other distinction I wanted to make is if they have other genes adjacent to SETBP1 that are also deleted. So if it's what we call a multiple gene deletion, they may have additional features and things may be a little more challenging for them. And so the reason, again, that I make this distinction is that within the community, as your community grows, there may be some heterogeneity or there may be some differences between individuals. And if you compare, if you compare one to each other, it's important to know what type of change, genetic change there is in SETBP1 so that you'll know whether or not we're talking about apples and oranges or apples and tangerines, or apples and potatoes, because there can be some differences even though we're talking about the same gene. The final thing, and I'll point this out a little bit, is some of the changes that we see in the SETBP1 gene. We have a guess, and I think it's a pretty good guess about whether these lead to what we call either the hyperactivity or the gain of function or the loss of function, but I don't think we know this absolutely perfectly yet. We haven't done actual experiments to determine the difference in all cases. Okay, next slide. So let me relatively quickly go through and explain what this is not again. So what I've shown here is a figure from one of the papers that was describing Gideon syndrome, and I'm showing in that top part A a schematic in terms of what that gene looks like. And what's very characteristic is you can see along the top of that bar some very specific, what we call amino acids or positions where we tend to see the changes in that gene. So it's amino acids 868, 869, 870, or 871. Those 4 very specific amino acids are located, and I won't go into the biochemistry, but it's localization within exactly that place that's associated with Gideon syndrome. Now, the reason I make the distinction is because there also are some cancers, in particular some blood cancers, in which we only see changes within that gene, and it can lead to cancer. And individuals with Gideon syndrome themselves, if they have those changes in those specific places, can also be associated with an increased risk of cancer. And the reason I'm making the distinction is because with the condition for this community I'm talking about today, I am not, let me underline, I am not talking about an increased cancer risk. And so even though it's early days, and I can't say this with 100% confidence, so far we have not seen an increased risk of cancer. And I think that's a really important distinction to make. I put it down here simply because I think you'll see by comparing to your children, these are pictures of children with Gideon syndrome, and to me, they don't have the facial characteristics, for instance, of your children. So I hope you'll appreciate that I do think they're very distinct and different conditions. Next slide, Lindsay. So as we're talking about this, by contrast, for this community that we're talking about, the change we're talking about in SETBP1 are changes where we are ramping down the function. So again, on that top line, what I'm showing you is that there are individuals who have deletions that have a missing part of the chromosome that includes SETBP1, and the length of the different red bars is to represent that different individuals have different size deletions. And again, the larger the deletion is, it includes more genes, sometimes genes beyond SETBP1. And in general, the bigger that deletion is, the more significant the impact is and the more challenges the individual can have. What I'm showing you in slide B in the middle there is that what you can see in contrast to the Gideon syndrome, the changes that we're seeing in the community that your children represent really are much more spread out throughout the protein, throughout the gene. And so they're everywhere from, again, I know it's a little bit hard to be able to understand this, but starting from the left, in that number 15 in the middle tells us it's at its 15th amino acid, so it's close to the beginning of the protein. It can be at 15 or 143 or 411 or 532 or 592, but you can see that it's spread out through many, many different locations, not simply at those small number of positions that I showed you within the last slide. And so many of these also, I won't go into too much detail, but for the slide I showed you before, those were changes with just one amino acid or one protein building block to another. So they were relatively subtle and specific changes. The changes, without going into too much detail here, when you see that star or what's called FS, meaning frame shift, those are different types of DNA changes which tend to abolish or destroy one of the 2 copies of SETBP1. And so again, those individuals generally we think of as having one functional copy of the protein. And just to show you by comparison, you can do a mental comparison to your own children. I've shown you some published figures of other children or other young people that have SETBP1, and you can even see in some cases some of the change in their facial features over time. Next slide, Lindsay. So to show you, this is again for the SETBP1 loss of function or similar to your children. And I'm showing you this because there are some cases, there are more cases published than just the ones that I'm going to show you about what was in Simon's VIP. And so showing on the left, this is about a dozen cases or so. And again, you're going to have access to all of these slides right afterwards. The 4 on the bottom represent deletions. So they have SETBP1, the entirety of the gene, and in some cases more genes that are deleted. And if you just look by, for instance, the pluses and minuses on the right, or pluses rather, I should say, on the right mostly. Every individual, if you follow that line across, I'll just take the very bottom line, for instance. There's a column for hyperactivity or ADHD, attention deficit hyperactivity, social difficulties. And if you read through all of those, you'll see that one person, the very sort of last line on this is a 4-year-old boy with a deletion that was new in that little boy, and his challenges were speech delay, motor delay, and some facial differences. So one of the things you'll notice if you look at those last 4 lines of the deletion and that very last column is that 3 out of those 4 individuals had seizures or at least abnormalities on their electroencephalogram or EEG. And in general, those individuals, there's more, it's more frequent to have seizures with the individuals with the deletion. Now, for the group I'm going to tell you about from Simon's VIP, we didn't have individuals with the deletion. We had individuals who are more like the top part of that table. And as you'll see from looking at that top part of the table, we in general, the published cases have seizures less frequently, but there are some individuals who do have seizures. And so that's one of those things I want you to plant sort of at the back of your mind. Some of the other things that you're seeing pretty consistently, and again, just in the introductions and to each other, I think you could hear the same things. Very consistently, we're seeing problems with speech. In these published cases, we're also seeing problems or challenges in terms of motor delay, so age at first walking, age at being able to do other things in terms of moving the body. That's what the motor part of it stands for. But there are also some individuals who are having behavioral challenges. So the things that people were talking about, the hyperactivity is one of the things, staying on task, staying focused is a challenge. And social difficulties, certainly as we were hearing about earlier, are not present in everyone, but there are individuals who are having some social issues. Another take-home message, which again, I'm going to talk through a little bit, but you're not seeing a lot of other medical issues. So you're not seeing on this table a lot of problems in terms of the way the body's working besides the brain. The brain tends to be the main place where we're going to focus our attention. And that's going to be true also of the cases or the information that we got from Simon's VIP. So let me just say one other thing, and then I'll say a little bit about Simon's VIP. So there's one case that I know a question came in specifically from the families, and so what I wanted to do was also highlight there is one case that was reported in amino acid 873. And the reason I'm highlighting this is, again, because there are some places, the other amino acids, just to remind you, that were associated with Gideon Syndrome were amino acids like 868, 69, 70, 71. But there are some published cases that are very, very close, but not exactly at the same position. So 873 is one that I'm showing you that has been published that's like that. And so far, what it looks like for those individuals that are close, but not exactly in what we call the Degron affecting region, amino acids 868 to 871, is they seem to be, in terms of the way they're manifesting, more like what your children are manifesting. So I'm going to make, it's a bit of a leap, but I think it's based on good information that everyone that's represented in the cases I'm going to be talking about are more like, not like Gideon Syndrome, but like the ones that are outside that region in other places. So for some of you on the phone, I don't know what your mutations are. And so the reason I put this in to begin this discussion with is I wanted to make sure that you knew which part of this to focus on. And if anyone has any questions afterwards, any of us who are medical professionals, I think, at least I speak for myself, and I think I speak for the group, we're happy to take any questions you might have about that specifically. Okay, next slide, Lindsay. So just to go over now what's in the group, and one of the things that I wanted to also let you know of is that for any of you who have participated or if you want to participate in the future, what we do is, again, we take away any identifying information so no one knows who you are. And the reason why we're talking about the results of the group as a whole is we don't want any one person to be singled out in this. And so it's a small group, but we're trying to protect all the children's identities. So as you'll see for the first 4 of these are all outside of the region that I talked about, and they're all clearly disrupting one copy of the gene. And I don't know if this person is on the call or not, but for the last one of these, again, it's amino acid 874, which I think is outside the critical region, but it is this different type of genetic change where we're substituting one amino acid for another. And so the laboratory that reported this result originally said it was uncertain. They weren't 100% certain that that was the cause of the individual symptoms, but my best guess is that it probably is, but I understand why the laboratory said it was uncertain because the evidence behind it is a little bit weaker. Next slide. So going through this, and again, I tried to highlight the things first that were most consistent across all of the 5 children. And again, remember, we're only going up to sort of middle of adolescence, so I still can't tell you about manifestations that might be present in older individuals, adults, and beyond. But consistently, we were seeing across everyone, which is no surprise to this group, but problems in terms of delays, or in some of the older children where we could measure an IQ, intellectual disability. But one of the things I want to emphasize is everyone continued to progress. Everyone continued to advance. They continued to learn. They continued to make progress. So all the things that I think the families, you all are doing right now in terms of educational strategies, aggressive, sort of creative ways of learning how to communicate and learning how to read are very important to continue doing. Within this, in terms of impairment, certainly expressive language in particular was challenging and difficult. I do think the kids understand a lot more than they're able to communicate, but specifically expressive language was a challenge. Only one of the 5 individuals had autism in terms of having a diagnosis of autism, but I do think it is possible to have some of the features of autism, but not have all of the features of autism. So in other words, not to have officially autism, but to have some of the features. So some of the things that we can see with children with autism about sensory issues, about clothing on tags, brushing teeth, brushing hair, some of those sensory issues are what I'm referring to. That's oftentimes some of the things that we see in autism. And your child may have that feature, but they may not have autism per se. The other thing that was very, very common was problems attending or problems focusing. And I think Dr. Sid's going to be speaking a little bit more about this, about treatments for this, but very, very common within this condition. Next slide. So, and you can go to the next slide, Lindsay. So now I'm going to focus on the medical issues that we saw, so things affecting the other parts of the body. And again, one of the things that I think the take-home message from this, if you're taking notes or trying to think yourself about where to focus, is the good news to me is there really was not a lot, or at least there was not a lot outside of what we see with most other children generally, or children with neurodevelopmental problems. So starting out from when the children were babies, we saw a little bit of things when they were newborns, and I put these in the slides not so much for you as families, but for families in the future who might be diagnosing younger children. But there was a little bit of breathing problems, a little bit of, if you remember, children that were a little bit yellow when they were newborns and may have required some light to get rid of the bilirubin, but they did fine with all of that. Next slide. In terms of some of the things that people noticed very early on, and in some cases it's because parents were very much attuned to their child, maybe they'd already had children or been around babies, but issues in terms of muscle tone being low, problems feeding, problems breastfeeding, or being able to suck from the bottle right away were some of the first things you noticed. Next slide. In terms of this, what the neurologists have also noted is what we call hypotonia, or low muscle tone. That is, that things were just not as strong. And many of the children have been going through physical therapy, which has been helpful in terms of improving that tone, making them stronger, making their core tone better. But that's something children, I think, continue to benefit from in terms of that. One of the children was diagnosed with cerebral palsy, or CP. In retrospect, I think that may have been an inadvertent diagnosis, or sort of the best diagnosis that we had at the time, but undoubtedly the more correct diagnosis is really, as we now know, the SETBP1 diagnosis. Next slide. In terms of vision, there have been some what I call minor problems with vision, needing to wear glasses, either because they had trouble seeing far away or astigmatism. One of the points that I'll make, though, is that when children have challenges with their brains, it's important that all their senses are working as well as possible. And so, for instance, I do think it's helpful for children to have their eyes checked, because if they aren't seeing the world clearly, it's harder for them to learn. It's harder for them to see, to be able to navigate and understand what's going on around them. And the same is also true for their hearing. So if your children haven't had their eyes checked, it is one of the things just to make sure there aren't any issues. It's again, things very treatable, very remediable. Next slide. In terms of the gastrointestinal or the belly issues, there are a lot of the things that we see pretty commonly with children with neurodevelopmental challenges. So in the same way that muscle tone is low in the muscles, the arms, the legs, the core body, muscle tone can also be lower in the intestinal system. And that sometimes can lead to problems either with constipation and or diarrhea. And so the same person can at some days be constipated, and in some days it may feel like things are just running right through them. The other place where we can see this is what we call gastroesophageal reflux or heartburn. And that can actually be, cannot be pleasant. And so any of these problems can lead to, children just not being comfortable, and sometimes they can't express it. They can't say why it is, but hopefully you're either gastroenterologist or pediatricians many times are comfortable being able to treat this, and they're very good medications, at least for the reflux, to be able to make that feel more comfortable. And for individuals with constipation, also either dietary interventions or some medications that can help to keep things moving along. Next slide. In terms of infections, what I would describe is that the children did not have any more than the usual types of infections. They did have ear infections, but for those of you who have other children know that that's not uncommon. That's not specific to SETBP1. But the one thing that I think was good was that for individuals who had repeated ear infections, they went ahead and had ear tubes placed. And I actually think that that's a good idea. My magic rule is in a winter, if there are 3 or more ear infections, it's a good time to talk to an otolaryngologist or a doctor that specializes in putting ear tubes in, because we don't want the kids to feel like they're underwater in terms of hearing. We want them to be able to hear clearly so they can develop language and they can learn in school. Next slide. In terms of some other common things that we see in children, we had one child with asthma. Next slide. And again, that's not specific. We had one child that had, there's a tube coming out of the heart, and that child's had aortic regurgitation. In terms of severity, that's not necessarily a very severe problem, not something that necessarily needs treatment right away. What I really wanted to emphasize is there was not a lot of congenital heart disease, not problems in terms of heart beating, heart skipping beats. So in general, I describe this as a relatively minor manifestation. Next slide. We did see one child that was missing a kidney or had renal agenesis. The good thing is that most people have 2 kidneys, or at least if you have one working kidney, it ends up being just fine. But when we do see renal agenesis such that a child has only 1 kidney, we do monitor just to make sure that 1 kidney continues to work well. Again, these are very, very small numbers, but if your child has not had an ultrasound to be able to document and look and see that there are 2 kidneys, this is something you might want to share with your pediatrician as a possible manifestation with this, just to make sure we know that the kidneys are there, that there's no problem with water on the kidney, or any other anatomical problems that might pose a future risk. And again, I don't think this is anything immediate, but just as kind of a health inventory. Next slide. Again, remembering that these are boys that we were talking about in this series, we did see that it was relatively more frequent to have undescended testicles, or testicles that may still be up in the abdomen or up in the belly. We also saw one boy where the opening at the end of the penis was placed a little bit differently. The one thing that I'll say is that if the testicles don't come down on their own, it is important to have surgery to be able to kind of tack those testicles down in the scrotum. because if they stay up in the belly, they actually can be associated with an increased risk of cancer in the future, increased risk of testicular cancer. So it's not something that has to be done when the children are little, but if any of you have boys that are older, and if the testes haven't come down by, the time the children are 7, 8, 9 years old, or even perhaps a little bit younger, it would be good to have them tacked down, have them literally just sutured down into the scrotum. Next slide. In terms of how the children are growing, in general, they were growing well, but especially early on, there may have been some trouble eating, and so that may have been associated with some slower weight gain. Next slide. Again, I want you to remember that the children that we're reporting on are relatively young, but there was one child with scoliosis or curvature of the spine, and it is one thing that as your children get into the teenage years and adolescence, it would be good for your doctors to keep an eye on that, because that oftentimes happens more frequently when they're teenagers. Next slide. So altogether, as I said, the nice thing to me is that what we were seeing in terms of surgeries, we didn't see too much surgical burden, and we tended to see that once these things were done, they were taken care of. They didn't have to be repeated. And so the main surgeries that we saw were things like the tonsils, the adenoids, the ear tubes, and as I was alluding to before, the surgery that's called orchiopexy is how they keep the testicles down in the scrotum, or the hypospadias repair, being able to surgically fix the penis. Next slide. In terms of special diets, in part, I think people have been trying to see if there's anything that they could do that could help with some of the challenging behaviors. And so people have tried a variety of things, everything from a gluten-free diet, and there are lots of foods now available that are gluten-free, or eliminating dairy from the diet, lactose-free. And this is something, I don't think it's harmful if you try it. I don't think we have enough evidence yet to know whether or not any of these make a significant impact. But certainly we'd be interested just in terms of if you have tried things, what's worked, and I'm sure it's something good to share amongst the families. Next slide. Dr. Sid is again going to talk a little bit more about medication specifically, but within the group there were a variety of medications that have been tried for ADHD. As I was alluding to, the good news is that at least in this small group, we didn't see that seizures were very frequent. It's not that I think that they can't happen, because as I showed you from some of the published cases, clearly they can, but at least it doesn't seem like it's a common problem. Next slide. In terms of what was working, and I think, again, because the tension, the distractibility was a big issue, I do think in terms of, we did ask many of you what was working, what seemed to be most effective, and we do have some evidence in terms of a couple medications now that may be useful. And Dr. Sid is going to go into this a little bit more in detail. I don't think going into this there's anything about the gene SETBP1 where we could have said for sure one medication or another was going to be more or less effective. It's a little bit of just trial and error, but I do think rather than everyone have to trying and erring, certainly sharing this type of information among the community can be very helpful. Next slide. In terms of when children eventually were able to do things, again, in terms of expressive language, being able to speak, it's oftentimes been either one word or shorter sentences or simplified speech, but it is coming, it is developing, so definitely don't give up, keep working on that. The other thing is that now with some additional technologies, I think it's been much more, we've had a lot more channels or a lot more ways for children to be able to work to express themselves. So if any of you are using things like communication devices or assisted communication boards, whether they're electronic with the iPad or any that might be just charts, sort of on paper, cards, picture cards, flip pads, whatever you're using, these definitely have been helping in terms of the expressive language. In general, the other thing is individuals have been gaining a lot of practical day-to-day skills in terms of being able to be toilet trained, being able to have be more independent and take care of both themselves with hygiene, bathing, being able to help with other things. But again, it's taken time, so be patient. But as you're focusing the educational plans both at school and reinforcing them at home, certainly work on some of those day-to-day activities and helping the children to be as independent as they can be. Next slide. So in terms of this, we've given you all the information we have, but clearly there are still a lot of unanswered questions. And part of what we like being able to talk with the families about are what are the important questions to you that remain unanswered. The ones that I could think about and put these down were just, again, as I said, are there ways that we can teach the children better, either strategies, especially for reading, strategies for communication, things that work in terms of, again, very practical day-to-day things that can be helpful. And if we need to use medications, what medications seem to be most effective, both in the short and the long term. Some of the sensory issues, besides just avoiding them, there can be ways of being able to sensitize individuals. In other words, exposing them little bits at a time until they can feel comfortable with some of those sensory issues. And those are especially important when it comes to things like brushing teeth, just in terms of dental hygiene. So there may be some strategies that you've thought about that you can share with each other. So next slide, Lindsay. So just in summary, again, most of the issues that we were seeing were associated around neurodevelopmental issues. I want to point out that we did not see any regression or individuals going backwards or losing skills. Sometimes if the skills aren't firmly grounded, they may not stick. And I don't mean that by regression, but when kids really, really have mastered something, completely losing that. We have not seen that. Again, in this small group, we didn't see any seizures, although they can be seen. And importantly, either in any of the published series or in anything we saw, we didn't see any cancer associated. Again, the kiddos are still young, but we haven't seen that yet. So let me just quickly go through the next couple slides because people often ask about this. There are remarkable advances that are being made in terms of gene therapy and gene editing. The very short story that I'll say right now is that this is looking promising as a general strategy, but we're not there yet in terms of doing it for anything like SETBP1 or similar conditions. I'm not saying it won't ever be possible, but right now it's not something in the short term we can depend on. So it's important for us to keep doing the day-to-day practical things you're already doing. Next slide. The idea is that there's new technology that's being developed to be able to literally take and correct one single letter in the alphabet, which is what really your kids all have, is one single letter that might be changed. It is important that this be tested out very rigorously and that it's very safe, because in prior attempts to use gene therapy in people, there have been places besides the target where we were trying to change the genes that have resulted in what we call off-target effects, which have even led to cancer or deaths in those individuals. So we want to make sure this field is developed really safely before we start trying it in our patients. Next slide. So in terms of being able to advance this, and I think Haley had the exact right idea, we are trying to make this easier for you all and make it easier for researchers to help you. And so with Simon's VIP, what we've been doing is any of the data that you're putting in, we're trying to minimize the burden for you all so that as you're putting this data, you can participate effectively in hopefully dozens of studies. That is, that researchers who are interested in this can come to Simon's VIP and be able to get your information and learn from you without you having to answer the same questions over and over again. And so this information is available de-identified, but to any researcher around the world who might want to be able to study SETBP1. And we hope this continues to grow over time. For those of you who have already participated, we actually come back to you on an annual basis to see how your kids are doing. And as we're doing this, we also, if anyone deposits anything like blood cells or skin cells in Simon's VIP, these can also be available to any of the researchers, so you don't have to get cells taken multiple times. Next slide. So as we're doing this, we obviously want to hope that more people get the right diagnosis and that this can make the group larger over time. As I said, one of my sayings is the care until the cure. So we want to make sure that before we have a definitive way of being able to treat this condition, we continue to support your kids and learn from each other as we're doing it. And as Haley had said, be able to help the research community by accelerating and catalyzing things like the development of cell lines in mice. And if we can at Simon's VIP, also learn things from other conditions that are applicable to SETBP1, be able to share those with you as well. Next slide. So one effort that we have at the Simons Foundation to increase the size of the SETBP1 community is a program that's called Spark for Autism. Spark stands for Simons Foundation Powering Autism Research for Knowledge. And if any of you are in communities or have for instance, at your children's school or maybe some of their therapy programs, individuals who couldn't get access to the exome sequencing that made the diagnosis for your child. Spark for Autism is a study of individuals with autism, so they have to have autism, but if they do have autism, they can register and they can be mailed a kit to their home where we can collect saliva or spit to be able to do that exome sequencing to make the diagnosis. It may not be that they have SETBP1 as a diagnosis, but if they have any genetic cause of autism that we recognize, they have the opportunity to get that information returned to them through the study, and it costs them nothing. So that's one of the things that we hope will have many individuals with SETBP1 diagnosed in the United States that'll help grow your community so that we can learn more faster. Okay, next slide, Lindsay. I'm going to just want to acknowledge there are many people that work behind the scenes. So you've met online Lindsay and Jennifer today, but there are a lot of fantastic people who help make this happen, and just want to acknowledge them. Okay, so I think we've got a couple minutes for questions here. So if anyone, Lindsay, I haven't been watching, but if anyone's put in questions through the chat, or if anyone wants to just go ahead and ask them, then I'll be glad to take questions.
Okay, I had one question come up through the chat during the presentation, and that was just how are the families able to find out the size of the deletion that their child has?
Okay, so for anyone, and I'm glad to do this offline, but you can either talk to your geneticist or whatever doctor ordered your test. If you had any of the changes, so I should have shown some changes way back at the beginning. So if your changes were any of those ones that were SETBP1 and then they showed a string of letters and numbers after them, those are changes that only affect SETBP1. It's not a deletion, and it doesn't include a larger size. And you don't have to worry about the size. It acts effectively all the same in terms of just eliminating one copy of SETBP1. If you had a change from a test that was probably a chromosome microarray, it would say that you had a change that had a deletion. And I know it's gobbledygook in those reports to read, but it actually tells you exactly the coordinates of what, we call them base pairs, but what region of the chromosome is missing and how big it is. And again, I'm glad to go over it with you on an individual basis, or your genetics doctor or neurologist or developmental pediatrician can go over it with you. But it's hard for me to know without seeing the specifics. So I'll be glad to take that offline and help anyone who needs help getting oriented. Any other questions?
I think I got one. I'm Jean-François.
Okay.
You have only 5 child for the study you've made,
Yes.
but you're still
Yes.
looking for to have more people.
Yes.
You have SETBP1. You want to have more than 5. You're still searching child to fill up the study you made. Is that correct?
Yes, so at this point, we only have, you're absolutely correct, we only have 5 people in SETBP1. We actually don't have a maximum number of people we could take. So if there were through the community, if you know about 500 more people, I don't think we do, but if you did, we could take 500 more people and be able to make this a more powerful resource for you and for any of the researchers studying it. So we have not capped it at 5 people, but so far it's only 5 people who have signed up and who have filled out all this information that I showed you today.
And these 5 people, it's maybe people that we all know all together. It's not a whole study that you've made 5 years ago or something like that. It's with the study you've made with VIP Simon and the work Oile do to publish it, to comment je peux dire, pour le publiciser.
So I'm not sure if I entirely understood that, but yes, you're right that it's only 5 so far. They are mostly recently reporting this information, so I do think it's pretty current and up to date in terms of that. In terms of the community, we're very anxious to make sure the community knows about this. On the other hand, we realize and appreciate that there are researchers, and I'm speaking as for Simon's VIP, what we're trying to do is get this available to the researchers who are studying and focused on SETBP1, so that if, for instance, they want to be able to publish on large numbers of patients with SETBP1 and be able to have a very comprehensive set, that they can take this information from Simon's VIP and combine it with perhaps other cases in the literature or other cases that they've established. So we're not trying to, be the ones studying this ourselves. What we're trying to do at Simon's VIP is mostly to enable the researchers who want to study, make it easier for you and make it easier for them. We kind of like matchmakers, we're trying to help put people together, but minimize the burden on the families. And if that doesn't happen just naturally on its own, we will figure out a way to get the information out to the community, but we're hoping that folks that are interested specifically in SETBP1, and you'll hear from Dr. Sid being one of those, and other people like Isabel around the world who are interested in this, we're trying to just make it easier for them to do their job.
Okay. So maybe we have, yeah.
Oh, and this is Jennifer. I just wanted to add a little bit more information. So we have 5 people that have reached a certain point of giving like a richer amount of information for us to return to. We do have a total of 12 families who have at least gone in and entered their initial registration information. And so as we go through the process over time, you'll have some families that have just started and some families that have gotten maybe midway through providing some information, and some families that have provided all the information we need. So so getting that message back to the family group about, the finding out from the study coordination team what else they need to complete. We do have other families that are already kind of in the pipeline to be providing that information. Okay, so it's just a question. It's just because you don't have time to put their in this study. It's just because they will be in further months. It will be done. You have more family, and in further months it will be done. But now you don't have time to put them in the 5 cases we talked today. Is that correct? Actually, we've provided back to you all the information that we currently have from families, but maybe there are a few other families who have signed up, but they haven't done their consent form, or they've signed up, but they haven't sent us their clinical lab report so that we can verify that they're kind of in the right group. And then they haven't been, so there's a sequence of events that happen. And different families are in a different stage, and so it's they might be busy, and that they don't have time right now, but maybe in a month or two they'll have had time to complete more information for us. That's great. I understand that one. Okay. It's a little bit hard for me because my English is not perfect. Oh, but, yeah. I think you're able to understand what I try to say. Okay. Okay. Thanks a lot.
Hello, this is Brian Hobson. So kind of along the lines of that question, I'm just curious, at what point clinically, how many children do you need to have in the study clinically before you feel like the results are statistically relevant?
So Brian, this is Wendy. I think more is always better. And the reason I say that is because in part, what I think is one of the bigger challenges is that everyone is not the same, for sure, within this condition. And I do think that in terms of different life stages, the more we know, especially about older children, the more it helps the younger children. So what I would say is there's no upper limit. For conditions that are rare, ideally we like to have hundreds, and we're not there yet in terms of that. And it's largely just because it's a rare condition and because not enough people have access to the testing that identifies that they have the condition. So what we're committed to doing is at least support the community as large as it can get, and be able to, like I said, help make that information back. So don't worry about, that we've got too much and that we don't need more information. Right now, I think we need all the information we can get.
Yeah, I was more asking about the floor, though. At what point is the minimum number where you really feel like that your findings are concrete?
I mean, I think
right.
I think the findings are pretty concrete in terms of saying for sure that if you have SETBP1, there are going to be challenges in terms of development and how the brain's functioning. I think there are low frequency events for other things, and I don't know that we have enough to see all the low frequency events, because in many just other conditions that are like this, we might have something that only happens to 10% of children. And, if we only have 5 kids or even 20 kids, we might miss something that only happens 10% of the time, or something that doesn't hit until people are 25 years old. But I do feel like statistically, not just from what I showed you today with the individuals in VIP, but also from the published cases, that this is going to be associated with, educational challenges, things coming more slowly. But I can't say for sure, like I said, that we know what's going to happen when people are 25, but, I feel fairly comfortable about the neurological things we're seeing so far.
So, and if there are other questions, I'll let other folks go. I have a few things popping up in my head.
I have 2 questions that came up in chat. So the first is, what is needed in terms of time and money to advance a potential therapy to the clinic?
So I'll just say very briefly, because this is a big talk, but one of the things we do work on is trying to also get, whether it's researchers in universities or researchers in pharmaceutical companies, but anyone to think about how to work on SETBP1 and be able to accelerate things. I will say that one of the things is that when I try and get pharmaceutical companies interested in this, they're very much driven by, they want to make sure if they spend a lot of money, maybe even millions of dollars developing a drug, they want to make sure there's someone who can use that drug. So their magic number oftentimes is 100. If they have 100 individuals out there, then that's something that they'll pay more attention to. And so that's part of why I'm trying to drive this in terms of knowing what the numbers are out there and making sure we can make a convincing story of that. We also, at the Simons Foundation, as part of what we do, we actually fund researchers. So in addition to aggregating things like this, we actually give grants for people to work on conditions like this. So if any of you are working with or know any of your doctors or researchers, definitely spread the word. There are ways to put in applications to do this. And it's not easy. This takes, this type of research often takes many, many years or decades before it gets to a treatment. But I do think those two things, and as Haley had said originally, doing things like having mouse models available, cell lines available, those are all things that definitely accelerate the research.
And then the second question, is what is the hypothesis as to why loss of function of the SETBP1 gene causes most of the symptoms present with the disorder?
So I think this particular gene is probably what we call dosage sensitive. That is, it matters to the brain especially to have enough of this protein to do its job, and that if you have even half the amount, that's not enough to do what the brain needs to do in terms of its day-to-day function. So in other words, in thinking about eventually therapeutically how we fix this, I do think that for most of the families that are on the line today, it's going to be restoring that function, getting it back closer to 100% of what it is, but importantly, not going overboard, because I think when you go too much on this, potentially there's an increased risk of cancer. So it's going to be finding that right balance to get it just back close to 100%, but not 200%.
So when you talk about restoring function of the gene, are you now talking about medication? You're talking about some sort of medical intervention, correct?
So it could come in the form of a medicine, like a pill you would take. It might come, as I alluded to briefly, in terms of gene therapy or having some way of either administering more of the protein or fixing the gene primarily. I won't go into a huge amount of detail, but it could be directed immediately on SETBP1, or there are also ways in which it might be directed around things that work around or with SETBP1, just sort of generically. And part of this is going to be dependent on, like I said, how robustly gene therapy ends up being, how robust it is with other technologies to be able to fix this. So part of this is, at least in my opinion, is to make sure your kids are advancing and as healthy as possible, and then to facilitate for researchers to figure out these strategies so that when they are available, your kids are poised and ready to go.
So that's a future state kind of conversation, correct? I mean, there's not a gene therapy today that you would recommend or that, might be worth trying?
Correct. So I absolutely do not think there's anything safe in terms of gene therapy for SETBP1 right now. I think in terms of timeline for that, we're probably talking at least 5 years into the future and perhaps longer in terms of as that science is maturing and developing. And I think what we're going to be watching for the community here is seeing how that develops for other conditions, other neurological diseases, and being able to learn from that. So when it is mature, when it's safe, when it's effective, then you're sort of in line, ready to go. But I think based on a number of factors, there's some safety issues that I think we really need to make sure it is safe for the kids. And in the meantime, there's a lot of potential for them to grow, especially using some of the technologies that are available and will be available in the future to support them. And so I think that's personally what I look for, is being able to think about how do we, again, take most advantage of the way that their brains do work and how they are able to learn, and make sure that we can, treat the symptoms that they're having so that they can just be happy kids and, grow up healthy and be able to be ready when other treatments that are developed are proven to be effective and safe.
In general, is there an age where gene therapy starts to become less effective?
It's very good. Yeah.
Sorry, go ahead. Yeah.
It's a very, very good question. And one of the things that's a nuance on what Haley was talking about is there are ways of actually setting up mouse models to answer directly that question, to decide, is there an optimal age of gene therapy? And the bottom line is that those experiments haven't been done yet for SETBP, but I think they do need to be done before we would think about doing gene therapy in the kids. Because your question is absolutely right on target. Maybe this isn't going to be effective in people that are 30 years old, but maybe it's effective in people that are 13 or 3. So we need to figure that out.
Thank you. we're just firing away. I appreciate the information.
Okay. Well, I don't want to steal Sid's time, so maybe we can transition over to Dr. Sid.
Great. Thank you so much. Can everybody hear me?
Yep.
Great.
Yep.
So today I'm going to talk about medical management of neurodevelopmental concerns and SETBP1. And thank you for those listening who completed the survey on developmental medicine concerns. I used this survey to focus my talk on key areas of concern for affected families. And I don't have time to touch base on every aspect, but I'm going to answer questions at the end of this talk and talk offline in more detail for any remaining questions. So here is an outline of my talk. I'll present some background information, and next I'll talk about motor impairment, intellectual disability, language disorders, ADHD, anxiety and depression, aggression, self-injury, and restrictive repetitive behaviors in the context of SETBP1. And I'll wrap the talk up with some conclusions. Next slide. Before I proceed further, some general warnings. So keep in mind that non-medication interventions can be effective too, but I wanted to focus my talk on medications for this purpose. And the information I'm going to tell you about is a combination of anecdotal data, some observational data from individuals with SETBP1 disorder, and some extrapolations from other neurodevelopmental disorders. And just in general, there is a great need to provide evidence-based research on neurobehavioral outcomes and interventions for SETBP1, which I'll address at the end of this talk. So first, some background. As all of you know, SETBP1 disorder is a genetic disorder associated with distinct facial features and a full variety of different neurodevelopmental presentations that include intellectual disability, attention deficit hyperactivity disorder, autism spectrum disorder, hypotonia, delayed motor development. So why is it important to address challenging behaviors and developmental concerns? Well, the answer is pretty easy, pretty simple. these concerns can affect the quality of life for affected individuals and their families. And addressing these concerns early on, whether that's through medications, whether that's through therapies, whether that's through some other form of intervention, addressing those concerns could, in theory, help long-term outcomes. And it's no surprise then that in the survey completed by some families, more than half of families reported that their child was taking medications to manage developmental and or behavioral concerns in SETBP1. Let me spend a few slides just talking about development in general, because I think it's important for the understanding of this talk. So when I talk about development, what do I mean? So child development refers to a timed, ordered series of events or milestones that take place, affecting domains such as motor skills, language skills, socialization, or cognition/problem solving. And then neurodevelopmental disorders then are disorders that affect each of these domains in certain ways. These are just clinical descriptions. So for example, if you have significant motor impairment, sometimes you can end up with the term or the label of cerebral palsy. Hypotonia and dyspraxia are two other examples of types of motor impairment. If you have predominant language impairment, that can be characterized by the term language disorder. If you have predominant language and socialization impairment, that can be characterized by the term autism. If you have predominant cognitive and language impairment, that can be characterized by the term intellectual disability. And behavioral problems can result in symptoms of attention deficit hyperactivity disorder, anxiety or depression, aggression or self-injury, and repetitive behaviors. Now this is a vast oversimplification, but you get the idea. And in SETBP1 disorder, the full spectrum of developmental disabilities, it looks like, could occur. And the ones with the star or asterisks are the ones that I will focus on in my talk. So let's talk about motor issues in SETBP1. I wanted to mention two specific examples of motor impairment that you may come across. The first is hypotonia. So hypotonia refers to low muscle tone. And this is a non-specific finding that you can see in a number of different neurodevelopmental disorders, a number of different genetic disorders. So it's not specific to SETBP1. And then the second type of motor impairment I wanted to talk about is a description or label of developmental coordination disorder, also known as dyspraxia. And developmental coordination disorder, or dyspraxia, affects one's ability to learn and execute coordinated motor skill. And then these are impairments that affect a child's functioning, and they are not due to cognitive or visual impairment. So as you can see here, 6 out of the 9 respondents in the survey reported that motor control or coordination was an important target for medication therapy. And I just wanted to read a description from the survey that I thought was relevant pertaining to motor impairment. So global motor planning difficulties. Every aspect of my son's life is impacted by his motor planning difficulties. It has impacted his ability to learn to sit up, crawl, walk, sign language, talk, run, play games, write, and learn any new skill. So in terms of treatment of different types of motor impairment, here's a slide talking about that aspect. So for developmental coordination disorder or dyspraxia, occupational therapy can break complex motor skills into smaller motor tasks that make it easier to practice those different movements. Speech or language therapy can help train a child to form the appropriate mouth movements needed to make certain sounds to communicate. There's a form of physical therapy called hippotherapy that basically incorporates the movements of a horse to train motor, balance, and coordination. And it's also a fun kind of thing that children enjoy, working with horses. And then assistive technology can include things like dictation software or even typing skills to help, for example, with handwriting difficulties. Now, switching gears to talk about hypotonia or low muscle tone. So hypotonia in and of itself doesn't necessarily need treatment, but if it's associated with functional motor impairment, then physical therapy may be essential or beneficial. And that includes hippotherapy, which can strengthen core muscles. So now let me spend some time to talk about intellectual disability in SETBP1. At a very basic level, intellectual disability pertains to impairments in cognition. So when I mention cognition, so what exactly do I mean? So cognition refers to our innate problem-solving abilities, and IQ testing is one way of assessing this. So for example, here are standard scores from a sample IQ report. So focus on the full scale IQ number over here, the 65 over here. So here's how to interpret this. So take the full scale IQ, so take 65, multiply it by the child's actual age when they had the testing done, and then divide by 65. So that is your child's, or that is the child's developmental age, meaning that's how old he or she may act like or think like. So for example, if you take a 5-year-old child, and let's say that 5-year-old child has a full scale IQ of 65. So if you say 65 times 5, so 65 times 5 and divided that by 100, you end up with 3.25. So that 5-year-old child with the full scale IQ of 65 will have thinking skills or cognitive skills approximately at the level of a 3-year-old, 3.25-year-old to be precise. So intellectual disability then occurs when you have a full-scale IQ that is less than 70, so more than 2 standard deviations below the mean, and which is accompanied by significant limitations in adaptive or self-help skills. So these are things like toileting, feeding, dressing, and so forth. And one point to keep in mind is that IQ is not necessarily static. It can change over time depending on limitations of testing and also depending on the child's developmental trajectory, if they are accelerating, regressing, plateauing, and so forth. A wide range of intellectual disability can occur with SETBP1 disorder. And an important point is that from what we know so far, SETBP1 is what I would consider or classify as a static developmental encephalopathy, which is basically a fancy way of saying that I don't expect there to be regression or neurodegeneration later on in life. Now keep in mind that we're still in the early stages and more children are being diagnosed with this disorder. So in the future, we may expand the spectrum of what may come in the future, but from what we know now, I would not expect regression or loss of skills. Now, there are no intellectual disability specific treatments for SETBP1 disorder, but I do want to emphasize one kind of key point, that the academic demands and expectations are balanced with the child's intrinsic cognitive capabilities, because otherwise an imbalance can lead to frustrations and other behavioral problems. Meaning if the child's functioning at one level, but their expectations in school are exceeding what their limitations are, then that can lead to an imbalance, and that could lead to behavioral issues and frustrations and all sorts of challenges. So I wanted to now talk a little bit about language disorders in SETBP1. And language disorders, basically reflecting an impaired ability to communicate, are a pretty common challenge for individuals with SETBP1. Language is quite important because it's the primary way we interface with the world. And the way I like to think about language is that there are 2 components. So there's an expressive language component, and then there's an receptive language component. Expressive language is basically our ability to communicate thoughts and our ideas with the rest of the world. And then receptive language, on the other hand, is our ability to understand thoughts and ideas. Now, it's important to view language in the context of cognition or thinking or problem solving. So for example, let's say you have a 6-year-old child who has an IQ of 50. So remember that exercise I did before. So if you multiply 50% by 6 years, so 6 times 50, you get about, and divide by 100, you get 3 years of age. So that child who is a 6-year-old with an IQ of 50 should have cognitive or problem-solving abilities at the 3-year-old level, and in turn, their language abilities should also be at the 3-year-old level. So if you look at this graph here, this is a graph of their, on the y-axis over here, is their developmental age. So if you look and broken down by their cognitive age equivalent and their language age equivalent. Basically, how old are they in terms of their thinking skills, and how old are they in terms of their language skills? So a 6-year-old with an IQ of 50 should have thinking skills at the 3-year-old level and should have language skills at the 3-year-old level. So in contrast, look at the graph on the right. So this is a child who has intellectual disability plus a language disorder. So what this means is that language is disproportionately affected compared to thinking abilities. So for example, going back to our 6-year-old child. So let's say we have a 6-year-old child who has an IQ of 50. So their thinking skills are at the 3-year-old level. So 6 years times 50% is 3. So their thinking skills are at the 3-year-old level. But if we were to say that this child has intellectual disability plus a superimposed language disorder, their language skills are actually lower than the 3-year-old level. So their language skills are, say, 1.5. So their language skills are disproportionately affected compared to their thinking skills. So this is an example of a child who has intellectual disability plus a superimposed language disorder. So language was definitely one of the areas of concern in the survey filled out. 5 out of the 9 respondents reported that lack of effective communication was an important target of therapy. And in SETBP1, expressive language in some cases can be more impacted than receptive language. Remember, expressive language is our ability to communicate or express thoughts and ideas, and receptive language is our ability to understand thoughts and ideas. So in terms of treatment of language disorders, I like to think of 3 pillars for treatment of language disorders. So there's one-on-one speech and language therapy. There are play and social groups where children learn to model language and social skills from each other. And there's something that I call, or something that's known as augmentative and alternative communication, or AAC. So AAC, augmentative and alternative communication, refers to use of special devices that allow kids to communicate even if they are lacking spoken speech. So these devices can be high-tech. So for example, the picture over here where there is a mountable electronic device, or they can be low-tech. So for example, this handmade picture board. And AAC can be especially helpful for kids who are nonverbal or who have limited communication, perhaps maybe a couple of words or under, a set of words, but not an expansive vocabulary. And I know this is not a medication per se, but I think it's a great example of an intervention that could be helpful in unlocking communication abilities in a child who receptively may be able to understand more than that child may be able to express. So let's switch gears now and talk about attention deficit hyperactivity disorder, or ADHD. And this is a common feature of neurodevelopmental disorders, and SETBP1 is certainly no exception. So in fact, in the medication survey completed by some families, 80% of the people who responded, so 7 out of the 9 families, said that hyperactive, impulsive, and or inattentive behaviors and or processing speed difficulties were an important target for medication therapy. So ADHD is a disorder associated with inattention, distractibility, hyperactivity, and or impulsivity. And a couple of key points. So first, the symptoms have to occur in two or more settings, meaning at home, in school, for example, or at home in the therapist's office, for example, and they have to be functionally impairing, meaning teachers may say, well, these symptoms are affecting how the child is learning, or they're affecting homework time, or they're affecting some other aspect of that child's functioning. There are 2 approaches to treatment for ADHD, and often both are necessary. A non-pharmacological approach involves behavioral therapy, and the purpose of behavioral therapy is to provide families, parents, caretakers with strategies to redirect the child's behavior. So a misconception may be that behavioral therapy is more for the child, and actually I think it's a little bit more for the families, the caretakers, to give them tools with helping redirect behaviors that are challenging. If behavioral therapy is not effective, then medications may be necessary for the treatment of ADHD. And there are 3 classes of ADHD medications. There are methylphenidate products, which are stimulants. There are dextroamphetamine products, which are also stimulants. And there are non-stimulant products. And I'll talk about each of these. So treatment for ADHD often requires a trial and error approach. So you start with one class of medication and then you switch to another because of either poor response or side effects. So in this 3-step process, you could start with methylphenidate product, amphetamine product, or a non-stimulant. If that is not effective, either because of poor response or side effects, you could switch to a medicine that you didn't use in the first step. And if that is not effective, then you can switch to a medicine that you have not yet used, either in step 1 or step 2. I recommend a start low and go slow approach to ADHD medication management, especially because the metabolism of kids with SETBP1 may be different, especially as we are starting to learn more and more about the disorder. The main side effects of ADHD medications are decreased appetite and disrupted sleep, but both of these have solutions and don't necessarily mean you have to give up on a medication. You can make adjustments towards the timing of the medication when you give it, for example, that could address each of these concerns, especially for sleep. And for appetite, there are caloric boosters and other things like that to get around that problem with appetite. And then I would also recommend that you wait at least 1 week on a medication or a dose change before deciding whether that new medication or that dose change is effective or not. And I would avoid the temptation to stop a medication trial early unless there are serious side effects. So give it really 7 days of a trial with a new medication or a dose change before declaring whether that dose or that new medication is working or not. So choosing which medication really depends on your preference for duration of the medication and how your child can take medications. So within each class of medications, so with the methylphenidate products, amphetamine products, non-stimulant products, there are short-acting forms, which last about maybe 3 to 6 hours. There are long-acting forms, which can last about 7 to 12 hours. And then there are pill options that you can't crush or chew. There are capsule options where you can open up the capsule and sprinkle them onto food. There are chewable pills where you are able to chew or crush the tablet or the pill. And there are some liquid solutions. And then there are even patches where you basically apply the patch onto a skin and it delivers medication slowly over time. So among the survey respondents, here are some examples of specific ADHD medications that may be effective for individuals with SETBP1. I'm just going to read some of the responses from the survey. So this was, I don't know what medication specifically, but stimulants. So these medications improve his hyperactive and impulsive behavior. Okay. Adderall, so one child was on this for several years, kept him calm and focused. Ritalin and Intuitive, better attention and focus at school. No real impact at home, which is interesting. And Intuitive, and the reason I say it's that is interesting is because with ADHD, you would expect symptoms to occur both at home and at school. So if there's a discrepancy in if symptoms are occurring predominantly in one setting and not the other, it could suggest that there may be an environmental or additional factor, behavioral factor, or something like that that's influencing the symptoms. Tuniv is very hard to swallow every morning. And then from 4 individuals in the Simons VIP registry, one individual, as Dr. Chung mentioned, indicated that Metadate was most effective, and another individual mentioned that Focalin was most effective in terms of treatment of ADHD symptoms. Now, in terms of some snippets of adverse effects or poor responses to specific ADHD medications, I've included some examples here. So one participant mentioned, once again, referring to stimulants generally, he metabolizes them too fast. The dosage doesn't last as long as it should. So I wasn't sure about whether the child was on short-acting or long-acting formulations, but one possibility is to make sure that you try a long-acting form of a stimulant. And I've also even had sometimes given long-acting medication, sometimes twice a day, because even though that is not typically what is done, some cases, some children can have different metabolisms, different ways that they basically process medications, and you may have to use a long-acting formulation. Even though it's meant to be given once a day, you may have to give it twice a day, for example. And then one individual mentioned what I believe sensitivity to Vyvanse and Adderall, although I'm not sure specifically about what hypersensitivities these were. So let me talk now about anxiety and depression, which could be another challenge that's faced by a child with SETBP1. In the survey that some families filled out, 3 out of 9 families, or about a third, suggested that anxiety and depression was a problem. And it's not really a surprise because mood issues are a common challenge among a variety of different neurodevelopmental disorders and neurogenetic disorders. Anxiety and depression can have a variety of manifestations, and these can include irritability, excessive worry, perseveration, which means becoming fixated on one thing and not being able to stray away from that fixation, and social avoidance. And sometimes it can be quite difficult to recognize anxiety and depression, especially if you're dealing with increasing levels of intellectual disability. Sometimes there may be a misconception that if you have intellectual disability, you can't have depression, but it's not necessarily true. And I think it's a challenge to be able to recognize those kind of symptoms in a child who does have intellectual disability, particularly if it is in the moderate severe range or higher. As with ADHD, there are 2 approaches to treatment. So a non-pharmacological approach involves seeing if there are triggers for the anxiety or depression. There's a specific type of behavioral therapy called cognitive behavioral therapy that's useful for anxiety, but this is applicable more for individuals with SETBP2 or SETBP1 who don't have significant cognitive impairment. So often medications are necessary, and I've listed 3 broad categories of medications used in the treatment of anxiety or depression. So there are SSRIs or selective serotonin reuptake inhibitors. Fluoxetine or Prozac, sertraline or Zoloft are examples of this class of medications. There are other antidepressants, which I've listed some examples of. And then there are benzodiazepines, which I've listed some examples of, alprazolam, lorazepam. SSRIs, selective serotonin reuptake inhibitors, are often first-line treatment of anxiety and depression, and a low dose of an SSRI can help anxiety and mood states in SETBP1. But one caveat I wanted to emphasize is that SSRIs in some individuals could lead to behavioral activation. So basically worsening agitation, worsening escalating behaviors. Another thing I wanted to mention is that it might be really good to try to avoid benzodiazepines. So these include things like lorazepam or Ativan for the management of anxiety, just because there's a risk of dependency, and in some individuals, giving that medication can actually lead to what I call paradoxical agitation, meaning you expect the medication to calm the child down, but it has the opposite reaction. So aggression and self-injury, so aggressive behaviors can be quite a challenge for some kids with SETBP1. In the medication survey, 2 out of the 9 respondents said that aggressive, self-injurious, and/or explosive behavior was an important target for medication therapy. Aggressive and self-injurious behaviors can include things like head banging, hand biting, excessive scratching, and so on. And it's certainly no surprise that these can be a significant source of distress for affected family members. Now, in terms of the treatment for aggression and self-injury, so the 2 things I wanted to say. The first is that these behaviors often require a very detailed behavioral assessment. And the idea is to try to identify any potential triggers from the environment that may be setting off these behaviors. Because if you can identify the trigger, then you can remove that trigger, and then without any medication whatsoever, you can help reduce the behavior. The second point I wanted to mention is that it's really important to make sure to rule out any medical causes of increased aggression, self-injurious behaviors. So sometimes GI problems like reflux, or dental problems like cavities, or skin problems like a skin ulcer. If these are not detected and treated, they can lead to worsening aggression or self-injury. Now, in terms of medications for aggression in SETBP1, so there's a class of medication called a second-generation neuroleptic that could be an option. And risperidol is one example. And then other types of second-generation neuroleptics to consider include things like aripiprazole, which is known as Abilify, also known as Abilify, quetiapine, and olanzapine. And then in some individuals, a mood stabilizer, valproic acid or Depakote or lithium could be helpful, but just keep in mind that the data in general for behavioral indications in SETBP1 is limited. So one major caveat, so neuroleptics, so these second generation, these medications called neuroleptics that are used for aggression and self-injury, so there's a potential for some serious side effects. These serious side effects include metabolic syndrome and weight gain. So basically derangements and lipids or fats, blood sugars, and so forth, as well as gaining a lot of weight. I wanted to include some of the responses from the survey. So in terms of adverse effects associated with neuroleptics. So Abilify, aripiprazole, child became very, very violent. So in this individual, Abilify had the opposite reaction than what you would expect. It should help calm down the aggression, not make it worse. And then with another individual with too much Risperdal, he became drowsy and absent. So this alludes to a point, meaning that often you might have to try a dose that is lower than what you would normally try for a child with SETBP1. You just have to be careful in terms of dosing. And once again, the key point being go low and start low and go slow in terms of how quickly, how slowly rather, you go up on a medication. And then with another individual, risperidone, ask for food all day. So alluding to the weight gain that you can see with these class of medications. And weight gain is not a side effect associated with, weight gain is not specific to SETBP1, meaning that risperidone use is associated with weight gain, as are other neuroleptic medications. Okay, so now let's talk about repetitive behaviors. And these can exist separately, or they can be part of autism symptomatology. So once again, remember Dr. Chung mentioned the fact that sometimes a child may not have a full-fledged diagnosis of autism, but the child may have certain symptoms of autism or certain aspects of autism. So in the survey, 2 out of the 9 respondents suggested that repetitive behaviors were a worthwhile target for medical therapy, so about 22%. Repetitive behaviors can include stereotypy, so these are stereotyped motor movements. They can include insistence on sameness, and they can include compulsive behaviors, ritualistic behaviors. These can occur in general in higher frequency in autism and intellectual disability, particularly severe intellectual disability. So both of these can occur in SETBP1. And then environmental factors such as social demands, and then the presence of additional medical issues or additional comorbid conditions such as anxiety, sensory sensitivities, these can make repetitive behaviors worse. In terms of medication treatment for repetitive behavior, so again, I would start with a low-dose SSRI, such as fluoxetine or sertraline, which could be helpful for repetitive behaviors in SETBP1. And then, as I mentioned before, with SSRIs, the key thing to keep in mind is that sometimes they can lead to behavioral activation, so worsening agitation in some individuals. And then for difficult cases where there's really, really bad disruptive behaviors, one thing to consider is doing an SSRI but augmenting, meaning adding another medication, a second generation neuroleptic such as risperidone on top of that SSRI medication. So let me wrap things up. So there's a spectrum of different neurodevelopmental presentations associated with SETBP1 disorder. So intellectual disability, ADHD, language disorder, autism, motor impairment. In terms of treatment, the kind of general approach is, well, identify the target behavioral symptom or symptoms, and then tailor your medications based on the appropriately identified target. So if your main symptom is hyperactivity, then trying medications that address symptoms of ADHD. Or if the main issue is anxiety or depressive mood type symptoms, then having a medication that targets those type of symptoms, and so forth. And in general, there is a huge need to study what medications work and what medications don't work for individuals with SETBP1. And I'm really glad and really thankful for participants who are enrolled in registry such as the Simon's VIP registry, because we need more of that kind of data to help drive our patient care. So the last thing, I just wanted to kind of make a quick plug that I'm trying to get a collective group of patients with SETBP1, get basically a SETBP1 clinic off the ground at Boston Children's Hospital, with the goal being to optimize
Please record your message. When you have finished recording, you may hang up or press 1 for more options.
So the two goals being kind of one, optimizing long-term neurodevelopmental outcomes, and two being helping coordinate specialty care across multiple disciplines. And the clinic would help address neurological concerns like seizures, developmental behavioral concerns like autism or intellectual disability or behavioral challenges, educational concerns, questions about treatment, and we would partner with physicians in different departments for referrals and coordinations of care. And then there would be opportunities for research, including things like biobanking. So lastly, I just wanted to thank Haley Euler of the SETBP1 Society and all the SETBP1 families, and I'd like to thank Dr. Wendy Chung and the Simons VAP Project, and Dr. Mustafa Seen, who is my mentor at Boston Children's Hospital. Thank you, and any questions?
So this is Brian Hobson, Brian and Jessica. So kind of a frustration maybe, and this is maybe a question targeted towards just the genetic profession in general. But when we were handed the information that Olivia had at SETBP1, the geneticist basically looked at us and said, "Wow, I've never seen this before. Here you go." I mean, in not so many words. So I'm just wondering, this is great. I'm just curious how how do you get information out to your own community, your own colleagues, to understand it better? Just curious about that.
I think one thing that is great about foundations such as the SETBP1 Society is that clinicians who may not have experience with a specific diagnosis such as SETBP1, at the very least they would have access to the SETBP1 Foundation, and because it has connected with experts and clinicians who are knowledgeable and who are willing to talk about it and educate more. I think as a whole, I think we as clinicians who are part of foundations like SETBP1 Society, like we want to teach and we want to reach out, and we are more than happy to educate and talk to any clinicians or doctors or whoever out there. So I think the short answer to your question is I think you're right. It is a frustrating experience, but I think one of the purposes of the foundations like this is to educate, and I'm happy to for physicians out there in the community who have further questions, or I'm happy to kind of reach out and talk about any kind of specific neurological or neurodevelopmental concerns. And Dr. Chung, I'm sure, is also happy to reach out and talk and educate others. So does that answer your question?
Yeah, and then it's partially a impossible question to answer to some degree, right. But just curious, I second to that. I would ask, how big do you think the pond is, right? With this thing. I mean, when you look at autism and these other things that are kind of, as big as the sun. Are we in? How big do you think this community could be?
Right. I'll weigh my thoughts, and I'll also let Dr. Chung answer as well. I think one of the things that is leading to increasing number of diagnoses is that we have more sophisticated genetic testing at our disposal. So whole exome sequencing is something that's now been around for a couple of years now and is available on a clinical basis, meaning insurance companies sometimes, in many cases, will authorize payment. And that is leading to an increasing number of diagnoses too. And if you look back maybe like 5-10 years, that kind of testing was not as readily available. And so I think as we become more sophisticated in the testing that we are able to have at our disposal, I think that leads to more people being diagnosed who may not have otherwise been diagnosed, say, like a decade ago. So I think that's one source of increasing numbers of people who may come up with a diagnosis. In terms of how big of a pond, it's hard to know. Like, as it's hard to come up with a prevalence estimate at this point because we're dealing with such small numbers. But I think over time, perhaps, it'll take some time before we could be a little bit more accurate in terms of giving you that prevalence number.
And this is Wendy Chung. I'm going to throw a number out there, and we'll see whether I'm right or not at the end of the day. My guess is the prevalence for the SETBP1 type of variant we're talking about for your families is something like 1 in 50,000 to 1 in 100,000 in the general population, if I had to pick a number. So it's not going to be very common. I agree with what Dr. Sid said completely, which is that more testing is becoming available. If there's one thing the families could help do through efforts like Global Genes and others is to make sure that everyone has access to this testing. I mean, right now insurance companies are not allowing for access to enough people to get the diagnosis, and that's certainly slowing things down. As I said, we're trying to do things in terms of making this more accessible, but that still is the rate limiting step. The thing that I don't know how to attack, and if any of you are in communities where you can think about this, is, to me, one of the things that's going to be most informative for the community here is being able to identify adults actually that have this condition. Because ultimately, to know long-term what the issues are going to be, I'd love to know now so we can get a sort of leg up on them. And that community, if the adult community, is really not accessing genetic testing in the way that Dr. Sid said. Sort of accessing them and getting them involved is major priority, but I don't know how to do it effectively.
That's a really interesting data point. Thank you for throwing that out there. Very helpful.
Great. And then I have two questions through the chat. The first is, are there any medications or non-medications that are effective for just attention and distractibility?
So, meaning, I guess to clarify your question, are you asking about, like a certain subset of ADHD symptoms? Is that what you're trying to get at?
I'm not sure because it came through the chat. But
okay.
If I clarifying details, I will. Oh, yes, yeah.
Yeah. So so just any medication just for attention versus and can you repeat the question again?
Yeah, it was medications or non-medications effective for just attention and distractibility.
I see. Right. Okay. So in general, so we aren't sophisticated enough to say, so in general, what I would say is stimulants versus non-stimulants would be more effective for the inattentive type symptoms and the distractibility type symptoms versus stimulants such as from the methylphenidate product family or the amphetamine product family versus a non-stimulant medication such as clonidine or guanfacine or intunib. So I would recommend a stimulant versus a non-stimulant for the inattentive distractibility kind of symptoms. In terms of a specific type of stimulant that would be more helpful for that those types of symptoms, I don't think we have enough data to say at this point in terms of SETBP1.
Okay. And then the second question is, has ID improved with the SETBP1 group over time? And I'm not sure if this question is best for Dr. Sid or Dr. Chung.
I'll make sure Dr. Chung can weigh in as well, since she might have access to some of this data. I don't know if we have the longitudinal trajectory yet. Meaning, so basically, if we assess adaptive skills or cognitive skills at one point, are they different over time, or what is that trajectory? I'm not entirely sure if we have that data yet. But Dr. Chung, what are your thoughts about that?
Yeah, we definitely don't have that data. Just as a general rule, and Dr. Sid certainly weigh in, IQ So IQ in younger children is difficult to measure, and so I think it's very imprecise, and it can appear to change over time from a younger child to an older child, just because I don't think we did a good job of actually measuring it. So I think that's probably the reason for the greatest variability. Once we do get, for individuals, once we actually do measure it correctly, it tends to be stable over time. So in general, I'd say, it'll be stable in that way. I think the thing that, again, I had said before is I think what's changing is even if the IQ is stable, I think it's just technology that we're developing in society that in a good way we can use to support individuals even if they may not have normal IQs. And so that's actually, I think of it as augmenting or supporting, and that's where I actually look at tremendous opportunities in the future.
I agree. I think it's absolutely correct. So the younger you are, the harder it is to capture a precise IQ measurement. So obtaining IQ testing before age 5 or 6 can be quite tricky. And in fact, one question that comes up is, what's the difference between global developmental delay and intellectual disability? And one of the simple answer is global developmental delay is often kind of the precursor diagnosis to intellectual disability. But the reason you don't just say intellectual disability when you're, under 5 or 6 years of age is because you can't, fully, you can't as accurately capture their IQ at that point. So, we use the label global developmental delay, but with the suspicion that this could transform into intellectual disability later on past kindergarten. But, with the idea that once the child is a little bit older, after 5 or 6, when you are able to do a little bit more precise neuropsychological or IQ testing, you could be able to better accurately capture the IQ, which would be used for the diagnosis of intellectual disability.
And then if anybody doesn't have any additional questions, I did have one question that came up shortly after Dr. Chung's talk that we weren't able to get to, and I think this was just in the question and answer period we were talking a little bit more about gene therapies, which is the question is, what about creating a synthetic protein that can be injected? So I apologize, it's a little bit out of context.
Yeah, no. So, it's a great idea. That's obviously, at the end of the day, it's not just the gene, but the protein that's made from the gene. Some of the trick in that is you actually have to be able to get it into the cell, and you have to get it into the right cells. And so there are some technical things that are more difficult in general with that strategy, just to say very briefly. And a lot of people have thought about just if you could put the gene into the cell, then it would make the protein directly into the cell, and as opposed to just, we can't really give proteins by mouth and get them into cells, and even doing infusions of the protein into the body doesn't necessarily get them localized to the right cells and into the cells. So it's a little bit complicated, but in principle, the thinking is the right type of thinking. We just may need to accomplish that goal in a slightly different way. Are there other questions? Oh, go ahead.
I have one. I'm Jean-François. I found
Sure.
that it was very instructive what Dr. Chung and Dr. Sid where on my list? Okay, Srivastava, sorry. It was very instructive, and I really appreciate what I learned about with what you said. And I'm just wondering, do you think it's possible to have a PDF of your book presentation you've done?
Yes, certainly. It's fine with me, Dr. Sid. I think it's fine with you too. Is that correct?
That's correct. Yes, it's fine with me.
That's correct. Maybe you should just make sure that Ellie get the PDF, and then she could be able to send back the PDF to the other family. Is that okay with you, Ellie?
Sure.
Yeah, we'll be making all of these resources available. So it's a good question, Jean-Francois. And Simon's, particularly Lindsay, will work to capture each of the segments and get them, and I will make them available in as many places as I can.
Yeah, and I find that because when we speak with other specialists, for families, it's very hard to have a all picture of what we're living with our child and everything. And if we got the PDF of this, it's very easy for us to check and to show what our child have. And it's much easier, I think, if we got a paper of that.
And this is Lindsay. And I just want to let everyone know that I will be following up with everyone that is on the call. Plus, there were a couple of folks that couldn't make it. And on Monday, sometime East Coast time midday, I'll send you all several links. So it'll be the full PDF of the presentation, just like you requested, Jean-Francois. And then I'll have the recording of the presentation as well. And you'll get the full recording. And then I also edited out to break up the recording into the different segments to make those a little bit easier to share with anyone who might be interested specifically in the genetics portion or specifically in the medications portion. So all of that will be coming in just a few days.
That's great. I appreciate it. Great work.
Okay, when there are no more questions, what we'll do is we as the medical doctors and the Simons VIP team, we're going to get off of this call because, as I said, I wanted to allow the families to have some private time if you want to compare notes or want to be able to say anything that you want to say privately. Of course, you don't have to say anything if you don't feel comfortable as families, but we'll have one last chance for any questions and then we'll drop off the line, but keep the line open.
And this is Lindsay again. I had one more question via chat, was a follow-up asking, what about RNA medicine? And I don't want to mispronounce this, but I think it's just IONIS Pharma.
Mm-hmm. So Ionis has come, this is Wendy Chung. Ionis has come up with some ways of being able to use oligonucleotides, either to be able to, in some cases, decrease the amount of protein or be able to supplement when something's missing. That strategy is probably not directly going to be the best one in this case. The reason I say that is because what Ionis has done is either works for, there's another condition called spinal muscular atrophy where it's worked to correct some splicing problems. For the types of mutations that your children have, we don't really need to correct splicing. We mostly need to be able to get more of the protein product again into the cells. And so in a complicated way, and again, it's, I don't want to disregard the question, but it's a complicated answer. The bottom line is there are probably going to be some other strategies. Just the protein, probably rather the messenger RNA or the oligonucleotides may not get into the cells where we need them to, and we may not be able to get enough in that way. So anyway, keep thinking though, because we don't know where the right answers are going to come from. So I love the fact that you're thinking and being creative about all these possibilities. Any other questions, Lindsay?
No, I'm also with questions on the chat feature, so unless any of the other folks on the line have any last minute questions, we can start wrapping up.
Okay. Thank you. I was going to just add, thank you, everyone. Thank you very much, Dr. Wendy Chung and Dr. Sid and Lindsay and Jennifer for being on the call and giving us this chance. This has been awesome, getting to hear your information, and we will continue as a society, as you know, to be as active and involved in this as we can possibly be. So thank you all very much.
Okay. Thank you. Bye-bye.
Thanks a lot. Merci beaucoup. I appreciate it.